All right, well, we'll go ahead and get started. Thanks to everybody for joining us. This is the first ever virtual, the first ever attempted a virtual event for the Institute for the Study of Free Enterprise at the University of Kentucky, but we've got, I think, a really exciting one lined up. So I'm Chuck Courtemanche. I'm director of the Institute for the Study of Free Enterprise and also an associate professor in the economics department at the University of Kentucky. And I'd also like to thank everyone for coming to my 40th birthday party, as it turns out today. So this is for an economics professor, this is a gift that's hard to top with everyone coming together for this event. I'm a health economist, so this is a topic of great interest to me personally. And you know, the paramount importance with healthcare expenditures being such a first order policy concern. So our lineup today, we're going to be starting off by hearing from U.S. Senator Mike Braun from Indiana. He'll be followed by Dr. Larry Van Horn, then Dr. Brian Blase, and then finally Dr. Art Laffer. And after their prepared remarks, we'll be opening it up for Q&A. And you can continue to submit questions in the Q&A box on Zoom throughout at any point throughout the event. And I've also already received a bunch of questions from the registrations, and I'll be moderating and aiming to ask as many of those as we can get to as time allows. So lastly, before we begin, I want to thank a few people. I want to thank Cynthia Fisher and her organization, patientrightsadvocate.org, for generously sponsoring this event. I want to thank Trey Watson of Capitol Reigns and host of the podcast Kentucky Politics Weekly for his hard work in facilitating the event. And I'd also like to acknowledge our Institute's major donors, the Joseph W. Kraft III and Charles Koch Foundations. So just quickly, a bit about our Institute. Our mission is to generate intellectually rigorous research and an open dialogue to discover and understand how free enterprise affects people's lives and the well-being of society. And putting on events like this are really, alongside our research, they're a critical component of fulfilling that mission. So with that being said, I'd like to welcome our first speaker, Senator Mike Braun. So Senator Braun, that's right, we can.
There we go.
Zoom welcomes.
We don't often get a clap on many things as a senator, but I'll take the three that I observed. So this is great for me because it's been a pursuit I've had from the early days of being a scrappy Main Street entrepreneur. My degrees in economics back in '76, went directly to business school out east, and then had the epiphany to move back home. Wife and I have been business owners since then, she 3 years predating mine. '81, I left the largest kitchen cabinet company in the world, now started in our hometown in the backyard of a lumber company. Many other businesses have spawned in Jasper, Indiana. Mostly though, I was a small business with 15 employees for 17 years. Believe me, fringe benefits didn't really register often. And even when they did, they were so affordable, I never paid any CEO attention to it. And that's a misnomer because I really didn't have a company large enough to say you were the CEO until maybe 15 years ago. It became an issue right after the turn of the century, when every year the only way I could moderate my premium increases would be to raise deductibles or change underwriters. And that was okay when you had a few employees, but by 2008, we had grown from that one location. The office was actually in a mobile home, which I cite. I got introduced as being a double wide out here 2 years ago. No, it was a single wide office, overhead, keeping expenses low, always being strong on your balance sheet, which seems to be passé in so many places anymore. It got us through all of that, but still, I wasn't going to take the lame excuses that there's nothing you can do about it. Well, there was something back in 2008, and that's right at the same time we were navigating through the Great Recession, and everything I owned was a piece of commercial real estate, a warehouse. Everything I sold was an unneeded truck accessory. We had, I think, 10 locations in 10 states at that time. Now we have 70 locations in 40 states. 3 of my 4 kids have those problems. Healthcare never went away. That day, I went from being a victim of the system to becoming the insurance company. I self-insured. That saved about 25% out of the gate on a plan like mine. Then I said, well, what else other than becoming the insurance company can you do? They said, the healthcare consumer, your employee, wants to pay for nothing. Wants to pay for nothing. That's the way it's evolved. I said, yeah, that doesn't make sense. You never ask what things cost before you engage the system. I said, what can I do now that I'm the insurance company? They said, well, in addition to what I cited I'm going to save by not having their profit margin as part of my cost, they said, you ought to look at co-payments. I said, co-payments? Ours were $10 at the time. They said, if you get rid of them, you create skin in the game immediately. You'll have maybe a minor uprising because nobody wants to pay for their health care. I said, tell me more. That'll be another 20 to 25% savings. You pay for co-pays up front in your premium, and that's why everybody thinks it's free. Businesses, if you're in a tight employment market, don't really fiddle with their fringe benefits. Remember, I'm a scrappy entrepreneur. I said, let's go for it. We were stroking $1 million check for a fully insured plan, and I'm going to end on this because I think it'll generate some questions in the Q&A. And I said, I've got 300 employees. They utilize the system very seldom because they were unmarried males. Now, 12 years later, they're all married with families, most of them still working for me. But I had to get a catastrophic policy, which was $250,000, had to hire a third-party administrator, which was $125,000. So I was out of pocket $375,000 versus $1 million. I'm the insurance company. I had to bear the costs outside the deductible. Those were going to be about the same as they were the year before. First year, we saved $425,000 on $1 million plan the year before. I pay for all wellness. I'm interested in not remediating, but preventing. And I've exposed our insurance plan to the most aggressive transparency of any plan in the country. I've not had a premium increase now going into the 13th year. I'll let it rest at that because I've put enough out there in terms of what could work across the country. We've been a microcosm of it.
Thank you so much, Senator. Can you all hear me again?
We can. I can.
All right. Getting used to this Zoom format myself here. So, well, thank you so much for sharing. And yeah, I'd meant to introduce you by pointing out your economics degree and saying that was the secret for your success, clearly. So, well, thank you. And so our next speaker is going to be Dr. Larry Van Horn. And just a quick introduction. Dr. Van Horn is an associate professor of economics and management at the Owen Graduate School at Vanderbilt. And he also is, so he runs the graduate healthcare programs there. And he also founded and is the director of the school's Center for Healthcare Market Innovation. And he's the founder and CEO of Preverity Incorporated, founder and partner of LVH Economics, as well as a senior professional with competition economics. And he also sits on several boards. So Dr. Van Horn, thank you for being with us, and go ahead and take it away.
There we go. Hopefully you can hear me now. Thank you very much, Chuck. It's a pleasure to be with you, Senator Braun. I think that was a great tee up to the conversation that I think I'll start and Brian will clean up on the economics of health insurance. I think it's important to note that what is insurance? Insurance is there to indemnify against high consequence, low probability events. That's what insurance is. in the United States, we've lost our way in terms of conceptualization of what insurance is. It's all prepaid coverage, and that isn't insurance. And unfortunately, that's exploded to the point that it's eating up real wages and it's not creating value for individuals. So I've got a few slides here that I put together that I'd like to share. And I think Brian has as well. First, my dear employer makes sure that I make a disclaimer that everything that I say in no way, shape, or form reflects the official view of Vanderbilt University. And probably they don't want to be associated with some of the things that I'm affiliated with and support. But this is Larry Unchained giving you my worldview. And I've spent the last couple of years particularly engaged in the topic of price transparency. It's something I've taught and worked with my students on for many years, assigning them the exercise of going out and finding prices in markets for healthcare services, a challenging proposition that's eye-opening for them. But it's clear today that the healthcare prices do not reflect what's typically a market clearing equilibrium, reflecting people's willingness to pay and suppliers' willingness to supply based on their marginal cost. And one of the biggest problems is that with this dominant role of prepaid medical care in the United States, all the negotiation occurs between payers and providers, and they're negotiated in private, and they're confidential. And yet, over the last 10 to 15 years, we've seen this rise in high deductible plans where all of us as individuals who have employer-sponsored insurance find ourselves subject to these confidential prices because we have these deductibles. I'd also say that I don't believe that much of the rent capture in the industry is aligned with consumer value creation. It's very much driven by provider rates that they can obtain through a market structure. I'll show you a little bit about that. And what I found is that when I studied this last year, that providers were willing to offer prices that were significantly lower than they negotiated with third-party payers, and they must be profitable prices, at least covering their marginal cost for them to supply it. So I believe strongly that price transparency is the first move forward. Now, this is a little bit of backdrop history. The blue line at the bottom is the price of a new car. Looking back to 1978, the gray is Consumer Price Index. What's noteworthy here, this is a little bit old, 2016. A car is actually cheaper in 2016 compared to 1978. Healthcare prices are up 673%. There's only one industry that is less disciplined in pricing than the U.S. healthcare industry, and it's where Chuck and I spend our time masquerading as well. It's higher education, up 1,272%, and we see the price increases continuing even this year. One of the big areas that I focus on is the employer market. And this is, as of last year, the deductibles that the 180 million Americans who have employer-sponsored health insurance face. And so if 55% of individuals face at least a $1,000 deductible, 28% face at least a $2,000 deductible, 13% face at least a 13% face at least a $3,000 deductible. As Senator Braun alluded to, and I'm a small business person as well, in the small group market, it's even higher than that. And so if you look here, the world really changed in 2006. I'll direct your attention to the lower black, dark colored blue. This is from the Kaiser Family Foundation and HRET, looking at the type of health plan that employers are using. And so prior to 2006, there was almost no HDHP, which is high deductible health plan with a savings option. The world was dominated by PPOs. And now, as of last year, you see approximately 30% of health plan enrollment for covered workers is in a high deductible health plan. That changes the game. And as Senator Braun alluded to, we have now a significant segment of the U.S. population who, because they're facing the out-of-pocket costs associated with meeting their deductibles, they have real price concerns, and they need to have price information to make decisions. So being quick here, last year, Dr. Laffer here and I had a series of conversations, and here's, I like to personalize things. So last March, here are lab tests that I had ordered by my primary care doc at Vanderbilt. These are simple lab tests. And I'm a middle-aged, 50-year-old, and so this is a standard compliment. I had no idea what these were going to cost. Neither did my physician. But here is the bill that I got afterwards. So for that simple lab tests, they charged roughly $800, $850, net of contractual adjustments. I had to pay $144 for the lab tests. I had no idea. Below that, you see a chest x-ray. Doc said, hey, go down, just get a flat plate and PA chest x-ray. They charged $387 net of adjustments. I had to pay $192 out of pocket for a chest x-ray. If I had known that, and my physician had known that at the time we were sitting with one another, I'm very confident we would not have even had the chest x-ray. And so I got upset, and I said, I'm not going to pay the bill. And I told Vanderbilt their bill was wrong. And they said, no, our bill's right. I said, let me give you an alternative. So this is from Josh Umbear, Atlas MD, direct primary care service out in Wichita, Kansas. Here are the prices that you would pay for getting lab work if you were part of Atlas MD. My lab test would have cost me $27 out of pocket, 7 times less. On the chest x-ray, I go on MD Save, and within 1 mile, I could have walked in and spent $54 right across the street within 1 mile for the same chest x-ray. So their price was 4 times higher than market, and I had no idea. And this is the problem. People are increasingly faced with paying these prices and have no visibility into it. So with my dear friend here, we started a conversation, and that there's a picture with Larry and Joe Grogan, us having the initial conversation about this that Dr. Laffer brought to the president. And that started the conversation that Brian will follow up on, because he was intimately involved in the execution of this in the administration. But this is not new news. This is from the Wall Street Journal in 2015, showing that the self-pay cash rates are frequently 40% less than what the insurance company's paying in various parts of the country. So I embarked on a data exercise looking at what was the commercial prices, not charge. We all know the charge numbers are not real, but what is the net allowed amounts that are being paid to providers by insurance companies using their 835 clearinghouse data. And I looked at a billion claims, and I compared that to the exact same bundles for cash that were being offered providers in these markets. It's roughly $48 million in cash transactions, and I compared the prices. So I want to show you that. So here's some examples of the price variation for commercial in various parts of the country for services paid by third-party insurers, and this is the allowed amounts. This is not charge. So at the top, you see colonoscopies. The average, not a lot of geographic variation there, but what's important is it ranges almost tenfold between the minimum and the maximum in terms of, and as a percent of CMS as well. So there's tremendous price variation, and you see that in CT angiography, even mammograms of the breast vary 400%. It's noteworthy I put up here Mohs surgery for tumor removal. There's not nearly the price variation for that. Now that's a covered insurance surgical procedure, and there's not much price variation because in much of dermatology, it is cosmetic and elective, and their norm is to be much more concerned with pricing in general. So I think that's why you don't see the price variation there that we see in other areas. So if we go on and look at elective procedures, reduction mammoplasty, ventral hernias, again, the price levels vary, but the price variation is massive. And then the final example here is looking at vasectomies. And my friends in the administration were particularly interested in looking at the difference in price based on site of service. So if you just look at the Midwest region where we're talking about today, the average price was almost 2.5 times higher for doing the exact same thing in the office than it would be, in the hospital that would be in the office, and nobody knows. But look at that price variation. And that's a point that I want to make, because price variation is risk to a consumer. it's the challenge one has by not shopping, because you can get whipsawed. If there was only 10% price variation all around the same level, we can argue the level's too high, but the risk of it not having the information is lower because the probability that you're going to get saddled with a price that's 3 times higher than market doesn't exist. But what I did here was look at the interquartile range comparing insurance and cash. And what you'll see here is price variation is huge in insurance and actually de minimis in cash. So I threw out the outliers, just focus on the core of the distributions. And this is comparing the exact same service, cash versus insurance. And what you see repeatedly is on average, the price variation in cash is around 20%, and it's 5 times higher in the insurance market. So means and medians, averages has been advanced by providers is not useful information. We actually need to know the real prices because of the price variation. It would be akin to going out and buying gasoline in your local market and having the price of gas range between $2 and $10 a gallon and not knowing what those prices are. I did another little analysis looking at the outpatient commercial allowances compared to Medicare nationally. So this is looking at what are commercial plans paying for outpatient services compared to Medicare. And one is you're paying the same, that's in green. Red on the right side of that chart at the right is the scale at the right is 4 times Medicare. And so you can see that you have areas here that are notably many multiples of Medicare and areas that are not. If you look out at California, there tend to be much higher commercial rates compared to Medicare. And you can see kind of the point variation in various communities for the outpatient service bucket. But noteworthy, if you look at Minnesota, North Dakota, South Dakota, that center part of the country, commercial rates aren't nearly as high relative to Medicare. So there's a lot of variation in prices relative to Medicare across the country. One last deep dive into Florida. Same within the same state, but you look at 3 markets: Miami-Dade, Fort Lauderdale area, Jacksonville, and Tampa. Miami prices are 1.7 to 2.3 times in terms of the outpatient prices relative to Medicare, whereas in Tampa, it's 3.7 times. And so why is that the case? Well, I would say, as an economist, it's very much driven by bargaining power at the point of care. And so in Tampa, you have 84% of the hospitals in 3 systems, and they're getting 3.7 times Medicare for outpatient rates. And whereas in Miami, Fort Lauderdale, 70% of the hospitals are in 5 systems. So you have much less concentration. So we spent our time over the summer doing analysis to support the administration and Brian's work helping develop the price transparency rule. One final example here, just to show you that you could be better in a cash world, period. So assume that you have a high deductible with a $7,000 deductible and then a 20% coinsurance on top, and you're in DC. Well, if you had to have a prostatectomy all in, the average price is $33,825. With insurance, you would end up paying $12,365. You would exhaust your deductible, and then you have coinsurance on top, subject to an out-of-pocket max. Well, I can go to MD Save, and I can find providers who would do that all cash for $13,968. So if you were in the top 25% of pricing and you had insurance, you would be better off just using cash and never even touching your insurance. This is the opacity that is challenging for Americans to make informed decisions. So last slide in summary, we found results that are largely consistent with what the RAND Corporation has found, that commercial prices are on average 3 times Medicare. There's massive price variation, up to 400% price variation across markets. But as important, comparing a market basket of cash transactions for the same services is on average 39% cheaper than it is what third-party payers are paying on our behalf. And as Senator Braun mentioned, That's all coming through insurance premiums. We're paying for it at the end of the day. And so there's a tremendous opportunity for price transparency to be a useful tool to disciplining healthcare delivery. So with that, I'll hopefully stop my share and turn it back over to Chuck.
Great. Thank you, Larry. Appreciate it. I guess we can do Zoom claps. So I want to, so we're fortunate to have Senator Braun with us for another 20 minutes, and then he has to go do something that I'm sure is far less exciting. But wanted to kind of jump in now before we get into the next presentation. There are a couple, the questions are rolling in already, and there are a couple specifically for him. So if that's okay, I wanted to jump in at this point. Here's a doozy right away. Senator Braun mentioned covering wellness. Presumably that means no cost sharing for preventive items like an annual checkup. How do we reconcile this approach with the skin in the game concept? Shouldn't routine low-cost items like a checkup, routine dental care, et cetera, be transparently priced and borne by the consumer so that competition drives a market price? So that sounds like it was written by a health economist.
Good question. And for us, I wanted to start with turning the healthcare employee consumer into a real one. And when it comes to, I view our investment in wellness in more of an investment in avoiding a full diabetic case. If you can catch it by wellness, we do a couple things too. We do charge you more if you still smoke. We charge you more if you will not take a free biometric screening, because we view the biometric screening as the best tool to make sure you catch something before it becomes a full-blown case. And in our area, diabetes would be that main looming healthcare issue. So that doesn't mean that somewhere down the road we would have complete skin in the game. But for us, that was the way we started. And the wellness has kind of got more of an investment component to it. And to be able to make sure that you have some willingness to take care of yourself so you don't have to go to remediation.
Thank you. Here's one other one that's, what was it here? Lost it. Here's one that's definitely specific for Senator Braun. We need to create a federal all payers claims database so that the public can see these price variations. Will you, Senator, try to get this passed in the next legislation bill?
We've tried to do that among a host of a lot of other reform measures. And sadly, there's been a lot of outlier issues interfering from the 3 to 4 months after I got here to where we could work on that stuff. 80 senators, by the way, came up with an idea of how to fix a broken industry. That's like a 2x4 over the head for the industry itself. And many on one side of the aisle want to make it a one-payer system. And I'll throw this out there. If the industry itself doesn't accept the tenets of eliminating barriers to entry, full transparency, there should not be such a thing as a third-party agreement, especially when employers are paying all the bills, and robust competition. It's more like a utility otherwise, the way it is currently, and that's where you'd have an argument that the only kind of regulator large enough to deal with a out-of-hand industry that embraces none of the tenets of free enterprise would be the other side of the aisle's plan. And in fact, that's what's happened in most other countries. I think it'd be a shame because we still got time to have the best of both worlds to where we can keep a few of the value addeds here in this country that we've got, but those are diminishing the more costs just chronically keep rising into the future. And I've never seen an industry dig in harder than healthcare. I'm the first Republican to join the climate caucus. That's the second biggest issue out here, just not as urgent. That industry is embracing change for its own long-term well-being. The healthcare industry is doing the opposite. So that, among probably 79 other ideas, are all out there. They fight it, and if the president does it as an executive order, it ends up in court the next day.
Mm-hmm. Well, thank you. Let me get one more in here that I think is kind of targeted for you specifically. Politically speaking, it seems to me that meaningful price transparency, as you had touched on, some of the barriers politically. It seems to me that meaningful price transparency is unlikely to occur as long as major hospitals and medical providers remain largely opposed to it. And it's really, how can you bring them on board? How can you persuade providers to back price transparency in terms that resonate with them?
So I was a freshman state legislator in 2015. And I asked somebody that I respected in the industry, give me good, better, and best. Good would have been just a general transparency bill. Better would have been really having them post stuff on the web or in print. And then the big one would have been to get rid of those third-party.
All right.
I think you lost the senator.
Yes, I think we've rendered him speechless, as it turns out. Well, we'll see if he's able to reconnect here. Why don't we move on ahead with Brian, and then if he pops back in, we can put you on pause, Brian, if need be. Is that okay?
Yep.
So let's. So I'll just go ahead and introduce Dr. Brian Blase then. So Dr. Blase received his PhD in economics from George Mason in 2013 and is now the president and CEO of Blase Policy Strategies. He previously was special assistant to the president for economic policy at the White House's National Economic Council. And in that capacity, he coordinated the Trump administration's health policy agenda, leading to the development of the administration's policies to increase healthcare choice and competition. And so Brian is a prolific writer, regular contributor to the Wall Street Journal and New York Post, and many of his recent writings are on price transparency. So we're delighted to have him here to share his perspective.
Thanks, Charles. This is the most distinguished panel I've ever been a part of. Former recipient of the Presidential Medal of Freedom, participating with Dr. Laffer is true honor. Larry Van Horn and Dr. Laffer were running around the West Wing in the spring of 2019, and I got a call from my boss at the time, Larry Kudlow. He's like, I've just met with Art Laffer, and he is here on healthcare. Like, my gosh, the guy is an expert and works on everything. And they really led a lot of the charge behind getting the president motivated in the issues of price and quality transparency, and led to an executive order that the president signed about a year ago, which has spurred a couple actions that I will mention soon. Imagine going to the grocery store to buy milk, bread, and butter, but there are no prices. You check out, and the grocer tells you your bill will come in a few weeks. In about a month, you get both an explanation of grocery benefits from your insurer and a bill from the grocer for $150. You know this can't be right. A gallon of milk, a loaf of bread, and a pack of butter can't cost this much. You call your insurer. and they ask you, why are you complaining? Without their discount, you would have paid $250. They saved you $100.
Right.
Sounds crazy.
Brian, we've got Senator Braun back. Do you mind if I cut you off mid-sentence?
Oh, in the middle of my punchline. Go ahead.
That's right. I'm sorry.
Defer.
You can finish your sentence if you like.
No, go ahead, Senator.
So I think, Senator, we didn't get really any of your answer to that last question.
Okay, hit me with the question again.
So it was, the question was really about just the political barriers and kind of how do you do this without buy-in from hospitals and providers, and how do you get that buy-in?
Good question. Where I started is in 2015. I did this at the Indiana State House and had 3 different bills that could not get a committee hearing. It took 5 years, and I was checking back with some of my friends there. They got a few things across the finish line. Here, 3 of the 4 largest lobbies are insurance, pharma, and hospitals. And that's similar back in Indiana as well. When people get fed up at the state level, there's more connection between people fed up and their representatives. Here, I don't know that it's going to happen. I was disappointed that even what we got through before it got cut off by impeachment issues, and then COVID, and now police reform, we had 80 senators weigh in. I mentioned that earlier, but still the lobby fought it tooth and claw. We had 2 mild bills, and about all we really got done was surprise billing, that we couldn't even get real agreement on that. And that's the lowest hanging fruit out there, is getting rid of surprise billing. So the industry's strong. I think it'll be in their own worst interest if they keep fighting it, because there'll be something called the Bernie plan that really knocks them over the head if they don't self-reform, embrace what will shrink them as an industry, but keep maybe the best of what they've got, but do what everybody else does. Compete with full transparency, competition, no barriers to entry.
Yeah, thank you. I think if I can interject something myself here quickly, it's there's a tendency to look at the cost problem with healthcare in the U.S. I mean, because I teach on this stuff and study healthcare finance and insurance myself. There's a tendency to look at that and say, well, that proves that the free market doesn't work when it comes to healthcare. And the reality is really that, more like, has the free market really been tried when it comes to healthcare? And it's not hard to come up with, a host of different ways in which the healthcare marketplace looks nothing like what a free market would. And I think your comments are speaking.
LASIK surgery,
Ooh.
Best example of where does not involve insurance at all.
Mm-hmm.
And when I looked at that 10, 12 years ago, it was like $2,000 an eye. And now you can get it done for both in the $500 to $600 range. So that would give you an example of how the rest of healthcare could work if you got the archaic, process of insurance not having anything to do with indemnification. It's a prepaid plan for letting the providers, the insurance companies, and pharma loot, private business, because we pay so much more than Medicare and Medicaid do.
Mm-hmm, mm-hmm. And there's the questions are rolling in now. I think I'll just ask one more that connects a few of these different questions, which is, few people asking essentially, we're talking a lot about costs. What about the quality side, basically?
Yeah, in any type of transaction, you've got the spectrum of the lowest price to the highest price. And generally, that's measurable with the value, the quality that comes along with it. So I get that argument often from the healthcare providers, but that's to justify the fact that it costs us twice as much as most other developed countries, right, and the results aren't twice as good, so to speak. So, but that's still valid, and markets take care of that. You get the $2 item versus a $4 item, and there better be real advantages that are worth paying for But without transparency, people competing for telling you why it's worth more to spend $4 versus $2, you'll never get there.
Terrific. Well, thank you. We'll let you off the hook there, but we should all thank, because I know I'll have to slide out quietly in a few minutes. We should all thank Senator Braun for joining us, and for and in case it wasn't made clear earlier, I mean, Senator Braun has spearheaded a number of pieces of legislation related to this topic of price transparency.
And one other piece of good news for everybody, and I'll close with this, is we are going to drop a transparency bill that Cynthia's been working on, and others, and we're getting buy-in from a lot of the people that have been year and a half that I've been here. A lot more interest because it has not gone away. It's just been interrupted by other issues. It'll come back to it, not necessarily before November this year, but definitely next year.
Can I ask the senator a question? Just a quick one.
Mm-hmm. Go for it.
There's going to be another stimulus package coming starting on July 4th. There's going to get into negotiations that are serious. There are provisions there. One of the provisions that I've heard might be coming in that is to have a provision for transparency, taking the executive order and making it part of the stimulus package. Would you support that? And do you think there's enough support in there that could possibly make it through?
I'll support it with the full head of steam that I've had in supporting all of these reforms. If that does happen, it'll raise the profile of what many of us have been trying to do, but I'm guessing it'll be thwarted almost as vehemently as what the healthcare industry has done to date. So a lot of people fold here.
What's the last thing you just said there? I'm sorry, I missed. There'll be vehement opposition, of course, but how about the Democrats in the House and the Senate? Will they be
Democrat
healthcare?
Democrats, for some reason, only are interested in making it a one-payer system and have great allegiances politically to like the hospital system. So it's kind of a contradiction. And it could crack to where you'd get, especially with the profile of being in that phase 4, if it occurs. My gut tells me that it'll be lobbied against just as intensively as it has over the last year and a half that I've been here about reforming it in general. So I don't think we'll have, we're going to try it, but my guess is it won't make it any further than what other attempts have so far, sadly.
Thank you.
Thank you so much, Senator.
You're welcome.
We'll give the Zoom claps. And Brian, we'll let you resume mid-sentence right where you left off.
Thank you, Senator, for your leadership on this. It is refreshing to have a businessman who has dealt with the pressure of high healthcare costs and been successful at lowering what their employees are paying for healthcare to debate this issue with your colleagues. I do actually have a piece that's up in Health Affairs today that makes the case that the two rules that the administration has issued on hospital transparency and insurance company transparency, that those rules should be codified in any future coronavirus relief bills.
Great.
So I'm going to share, I put together a presentation.
You guys want to watch the rest of it?
Do you see my my PowerPoint? Okay. So I have written two pieces on price transparency. The first was published by the Galen Institute. This is the cover page. It was in the fall last year, and I reviewed sort of all of the relevant empirical evidence on the benefits that price transparency can create for consumers and employers. And then today, this is the piece I just mentioned. This is the new post at Health Affairs. I'm going to try to make some key points in the next 15 minutes or so. First, and this is very helpful for policymakers that are supportive of price transparency, 9 out of 10 Americans believe prices should be disclosed. And when this is asked, whether the government should require hospitals and insurers to post prices, you get about the same result. It's about 9-to-1 support. And this includes people like me, who almost uniformly oppose government mandates, but who recognize that there are serious dysfunctions in our healthcare system that price transparency can help solve. Out of last year's executive order, the administration has taken 2 major actions. In a November rule last year, the administration required hospitals to post their prices, the real prices, the actual rates that they negotiate with insurers, in a machine-readable format starting in January. Now, the American Hospital Association has sued, and they're attempting to block this rule. The rule would also importantly provide bundled prices for 300 shoppable services in a consumer-friendly online form. In addition to this action, the administration proposed a rule last fall as well to require insurance companies to post their prices. Based on how long it takes to move things through the regulatory process, I'd expect the administration to finalize that rule late summer, early fall. As Dr. Van Horn mentioned, there are major opportunities to benefit from healthcare shopping. One, because healthcare represents about 20% of the American budget, but also because there are such wide price variations, and people get the most benefit from shopping for items that are a larger part of their budget, and when there are wide price variations across suppliers and producers. There are 3 general problems with shopping in healthcare. There's an information problem. People don't know what prices are. There's an incentive problem, which both the Senator and Larry mentioned. And there's an institutional problem. The institutional problem is markets are increasingly consolidated, and also people tend to rely on their doctor referrals and will often bypass lower cost providers because of their doctor referral. Price transparency clearly solves the first problem, but I'm going to argue that it's also key to addressing both the incentive problem and helping employers with how they structure payment designs for their employees. And it also helps the institutional problem, in part because doctors don't know what prices are for the most part either. In the Galen piece, I discussed the 4 major benefits of healthcare price transparency. 1, better informed consumers and patients. 2, better informed employers, helping workers shop for value. 3, an improved ability for employers to monitor and eliminate counterproductive middlemen. And 4, public pressure on high-cost providers. What I'm going to do in the next few minutes is go through what I think are the 11 key takeaways from price transparency in healthcare. The first is that price shopping in healthcare is growing. Now, partly this is because, as Larry Van Horn alluded to, you have more high deductible health plans, and there's more incentives to shop when you're below your deductible. It's also that there are more tools available now. So about 1/3 of people in 2017 reported that they used the internet or a mobile app to shop for healthcare, and that included more than half of millennials. So shopping in healthcare is going to increase. Importantly, it's hard for many people to ask about price information in healthcare. In part, this is just because we haven't done this much, and because doctors often can't tell us what prices are. Well, it seems people are getting more comfortable asking about prices. Price transparency efforts will help people who aren't as comfortable directly asking their providers for price information. There's 2 key researchers that have really looked at the impact of price transparency: Zach Braun from the University of Michigan and Christopher Wally from the Rand Corporation. The second, a lot of the data that I go through in evidence is research that they've done. The second key takeaway is that consumers that do shop can save a lot of money. Zach Braun looked at consumers that used the New Hampshire website for online healthcare prices. He looked at it for people who used medical imaging. The biggest benefit accrued to people who had not met their deductible yet. And although a relatively small number of people shopped, people who did shop saved a considerable sum of money, an estimated 36% on the cost of the imaging. Number three, and I saw this as one of the questions that was asked, much of healthcare is shoppable. So this is a quote from the administration's report, Reforming America's Healthcare System Through Choice and Competition. A couple of statistics: only 6% of healthcare spending is done through emergency departments. One study found that 43% of spending is shoppable, with another 11% of spending on prescription drugs, which is generally shoppable. And importantly, this is just shoppable at the consumer level. Employers obviously do a lot of the purchasing on our healthcare system, and for them, virtually everything that they purchase is going to be shoppable. Fourth, healthcare is not too complicated for shopping. There's often a paternalistic argument as healthcare is too complicated for families and consumers, and we need a variety of middlemen and experts to structure our choices. That misses two key things in my view. One is that people rely on feedback loops like Yelp. They'll do that in healthcare just like they do on nearly every other thing that they purchase. And the second is that technology has made it much easier for people to do research, and they tend to do this research on just about all the products that they purchase. Number five, this is one that I am particularly excited about and think could be really impactful. Price transparency eases employers' ability to use reference pricing models. What's a reference pricing model? A reference price is when an employer or a payer says, we're going to pay a set amount of money regardless of the provider that's chosen for a particular procedure. What reference pricing does, in essence, is it creates a transparent price, and it also creates an incentive to shop, because anything, any price amount above that, what the reference price is, the consumer will have to bear out of pocket. Let me go through two examples with you that show the power of reference pricing. The first is with Safeway. In 2010, Safeway moved to a high deductible health plan, $100 deductible, with an online price transparency tool. The next year, they introduced reference pricing for labs and images. The result, and it allowed researchers to look at this sort of sequential impact of the price transparency tool with adding the reference pricing. By itself, there was no change in behavior from just the online price transparency. But when the reference pricing aspect was added, there was a significant savings as consumers started shopping. There was a 27% decline in the average price of lab tests and a 13% decline in the average price of imaging tests. Second example, CalPERS, California Public Employee and Retirement System. It's got about 1.4 million members, so it's pretty. It's got a significant presence in California. In 2010, CalPERS introduced reference pricing for orthopedic procedures, and I've got two figures to show you what happened. Here you can see the blue line. The blue lines are Anthem. It's the control group. So there's a set of high-price hospitals and a set of low-price hospitals. Reference pricing takes effect in 2010. What you can see here is that when reference pricing took effect, people changed their behavior. There was a significant shift from high-priced hospitals to low-priced hospitals. I mean, you say that's obvious. We would expect that. But what also happened is that prices plummeted at the high-priced facilities. This is an indication that the prices weren't justified, that they were making huge margins, and that they were not operating efficiently. So when people started shopping the high-priced hospitals had to lower their prices in order to attract enrollees. And you can see that's the significant feature of this picture. In total, the CalPERS reference pricing experience translated into a 9 to 14 percentage point increase in employees and dependents' use of low-price facilities and a 17 to 21% reduction in prices. Maybe the sort of neatest finding here, a paper by Christopher Wally last year found that the reference pricing experience in California produced significant external benefits. This means that people benefited even if they weren't part of the reference pricing model and their behavior wasn't impacted by it. In order to compete, the providers had to lower their prices, and 75% of the price reductions benefited people who were outside the reference pricing model. Here, if you can just, the key is if you can just induce a relatively small number of people to start shopping and using this price information, the effects could be dramatic and economy-wide. Number 7, transparency will allow employers to better monitor the TPAs and insurers that they have hired to help them. Because of the significant amount of third-party payment in healthcare, economists often refer to it as a principal-agent problem. Principals will often hire agents because they want to outsource work for the agents, or they want to outsource work to the agents. But a problem occurs if the agent's interests aren't aligned with the principal's interests. Clearly here, employers want to lower what they spend on healthcare so that they can increase wages and attract workers. Agents, which here would be the insurers, may have an incentive for higher spending if they are basically making a percentage of total spending. And I think what we have seen, and Larry mentioned this, is that in some places of the country, prices, particularly for outpatient care, are so much higher than what Medicare pays. That insurers and TPAs are really failing in their job to secure good deals for employers, often more interested in just the discount that they get and that they get the best discount. Well, these discounts are really meaningless because you're discounting off of outrageously inflated charges. And the information, the price transparency information, I think was really going to help employers to monitor the TPAs and insurers and be able to compare prices both within their area and across the country to see what appropriate price points are. Number 8, transparent prices will help employers develop improved benefit designs. So it'll help employers know where there are low-cost facilities where they can try to direct employees to. It'll help employers set up direct contracting, where they just enter the relationship directly with the provider and sort of cut out the insurer and the middleman and avoid a lot of the administrative costs. And importantly, it'll help providers be able to maximize sort of what Walmart does. Walmart has centers of excellence where for certain procedures, they identify facilities outside their local area where they will pay the travel costs and the room and board for patients and often a loved one to go and get care in a facility outside their area. With expanded transparent information, that's going to be easier for employers to set up. Now, I'll play this video. So that was Keith Smith, and Keith Smith heads the Surgery Center of Oklahoma. That video was produced by the Patient Rights Advocate, and there's a lot of really great videos and stories that Patient Rights Advocate has identified of employers and patients taking advantage of price transparency. What Dr. Smith is referring to here is a patient who was quoted $40,000 by their local hospital, called his price transparent surgery center, and was given a quote of $3,600. She then called back the hospital in her local area, and they were able to do the procedure for the $3,600. So just the threat of consumers leaving a local market will put pressure on local providers to lower prices to marginal cost. And that's where we want prices to go, to what the marginal cost is. Number 10, transparent prices should put public pressure on high-priced providers to lower their rates. I do think there's, with greater price transparency, you're going to have a degree of shaming that occurs with some of these prices that are so outrageous that they can't be justified. We've seen something similar happen with a lot of the media coverage around the collection practices of some hospitals. In Virginia, we've had two, Mary Washington University Hospital and the University of Virginia Hospital, who would sue patients and put them into collections over unpaid medical debts. When that practice was reported on by the media, within a week, both of those hospitals changed their business practice. Finally, price transparency will not enable collusion, but it will enhance competition. These quotes are from the Galen paper that I wrote. One of the concerns that we grappled with a little bit when I was at the White House were issues raised that price transparency might enable collusion. A lot of the economists that I talked with and consulted with, everyone sort of casts a lot of cold water on that concern. Local markets right now are characterized by only a limited number of participants who engage in repeated interactions. They already have knowledge of each other's payment rates, particularly to each other. Moreover, hospitals and other providers do provide pricing information. It's just after the fact in these explanation of benefit documents that patients receive. I do think the real reason that the hospitals and insurers are opposing price transparency is because a lack of easily accessible price information has allowed them to remain inefficient. They can deliver mediocre or even poor care at high cost and still see their bottom lines improve. Finally, I mentioned before that you don't need a lot of shoppers in order to make a difference in high-price facilities lowering the prices and introducing that competitive pressures. Zach Braun did modeling on this, and he suggests that with as few as 10% of individuals being informed about prices, you're going to be able to negotiate lower prices for providers. In conclusion, I support Senator Braun's efforts. Congress should codify the administration's rules on healthcare price transparency. They also need to be more vocal about the importance of the actions that they've done and the benefits that the American people will receive from transparency.
Great. Thank you, Brian. So batting cleanup today, we have Dr. Art Laffer. And Dr. Laffer is the founder and chairman of Laffer Associates, an economic research and consulting firm. He's, of course, famous for the Laffer curve and has distinction in many publications as the father of supply-side economics. Dr. Laffer was a member of President Reagan's Economic Policy Advisory Board and was a founding member of the Reagan Executive Advisory Committee for the presidential race of 1980. He's also advised Prime Minister Thatcher. In 2019, he was awarded the Presidential Medal of Freedom by President Trump. And he currently sits on numerous boards and has authored several books, including most recently Trumponomics, Inside the America First Plan to Revive Our Economy. And he's also written extensively about price transparency in healthcare, and we're excited to have him here today to discuss those insights. So let's welcome Dr. Laffer. Need to unmute.
There you go.
I'm almost 80, so I have a flip phone. I don't have a computer. But let me just say, Brian and Larry were instrumental in the executive order that was signed by the president on transparency. I mean, just phenomenal. Brian, as you know, worked for my best friend, Larry Kudlow, and did just a phenomenal job in making it all happen. Larry Van Horn was brilliant. He's been one of my best friends for years and years. This stuff is just amazing. And I take if I had a hat on, Brian and Larry, I'd take it off to you too for the wonderful job you've done here. I mean, if you look at this from a standpoint of macroeconomics, price transparency, and the results that are going to be done, Brian, both you and Larry point to the very sharp drop in the prices for the same product. You can argue it the other way, is where you get the same total amount paid, how much more healthcare you'd get. The best article I've seen in a long time on the understanding of this is by George Schultz and Jorgensen this morning in the Wall Street Journal, which is just a phenomenal article there. It's about Singapore and the costs that they pay for healthcare and the benefits they get and longevity and all of that. It's really important. But let me just go to you. Healthcare maybe is a little bit less than 20% of GDP. Reducing the price of healthcare by only 10% will add 2% to GDP. If you reduce it more, it'll add more. This will increase real wages, it'll increase productivity, it'll increase participation rates. It will create a new political economy of growth here in the United States, which will provide the ability for the U.S. to employ people, raise the standards of the lowest livers. It is the central tenet for creating a long-term economic prosperity, dynamic competition in this area. I'm on the board of a company which is called Bridge Health. Now, Bridge Health is primarily owned, the primary owner of that company is a man named Jared Polis, who happens to be governor of the state of Colorado. This is where we look and we try to do, Brian, just what you suggested, is look all across the hospitals, provision of a standardized service, get a very high quality and also very low price, and try to drive business to that area to save self-insurers a lot of money on their processes. It's been working beautifully. This is one of the key elements to creating economic growth and prosperity in this country. I would put it right along the lines of the 2017 tax bill. I would put it right on the lines of any of these other process, macroeconomic policies. Healthcare is such a large area. It's so lacking in any type of competition. It's amazing. This is just the low-hanging fruit that really can be done and needs to be done politically right now by the process. I hope we can slip it in the bill, Brian, and make it so that we can put it in there with some other provisions and make it negotiable so we get the executive order and legislative language to get it passed. I don't know that that's possible or not, but I think there's a chance we can do that. I mean, when you look at this and the country and economic growth, this is one of the biggest answers. The other answer, which I would prod my little friend Larry Van Horn over here, the other answer, of course, is universities, but we'll have a webinar about that a year from now when we free up universities by not allowing deductions to be tax deductible, not allowing contributions to be tax deductible. They're forcing universities to pay taxes on their property and all those other things. There is no reason why they should be tax exempt and why they shouldn't be required to do price efficiencies as well as healthcare. But healthcare is the central macroeconomic policy to create economic growth. And again, Brian, I want to take my hat off to you and to Larry for doing such a damn good job on this. And I hope everyone here, we can all benefit from it. It's just amazing. I have personally done my own personal provisions for healthcare with cash. If you walk into a hospital with a wad of cash, it's amazing the prices you can get if you shop around a little bit for great things. And it's been true for a long, long time. Now we have to make it where everyone, all people are allowed to do that price transparency and price shopping. You get the highest quality products for the lowest costs, and it will really rocket ship this economy. And I'm gonna leave that, Chuck, for you and throw it open for questions.
All right. Thank you, Dr. Laffer.
Oh, stop.
All right. On the note of a rocket ship, so there's 26 questions in 18 minutes. I'm going to do my best here to kind of consolidate questions and try to hit a few of them at once, and we'll see what we can get through. So one that, and these, anyone who wants to, any of the panelists who want to jump in and take them, go for it. Zoom should automatically feature whoever is talking. So one question, would the panelists please define price transparency and discuss evidence on why forcing healthcare providers to inform patients of costs before care is administered will actually reduce prices versus the independent effect of copays, for example. So I see this as, what evidence do we actually have currently about the effectiveness of price transparency?
So I'll jump in. So a couple of points. Brian went over a bunch of the research that I think is quite compelling. I think an important point to distinguish between real prices and copays is copays don't vary typically based on provider. And actually have no incentive to shop whatsoever because you're going to pay the same $10 or $20 copay, irrespective of what your provider is being reimbursed behind the scenes. So the real price is what matters. And the problem we have now is that even if my insurance company put forward a pricing engine, it's with the prices that they've negotiated, which are typically wrong. They're in their network, which doesn't allow me to see what's going on outside their network. And furthermore, what I really want to know is if I'm going to ride on their insurance prices, I want to compare it with my other insurers in the market. We need a lot more transparency across the board for me to be able to make the sensible decisions with my $6,000 family deductible. Brian?
Yeah, I mean, that's a good answer, and that's for the consumer. There's also the issue of employers. So employers do a huge amount of purchasing, and I really, in my thinking, the main reform is going to happen through employers redesigning their benefit structure, and price transparency is so crucial in order for them to direct patients to where you get the highest value from seeing that particular provider for that particular service.
Good. Thank you. So next question. What fraction of health expenditure can truly be considered elective in the sense of, like we as economists would think about the assumptions of perfect competition, homogeneous products, where truly you're just differentiating on price? A specific part of this question, how would price transparency work for cancer care, et cetera?
You need not only price transparency, you also need product transparency and quality transparency as well. Just because you know the price, that's not enough. You have to know what you're buying and what it costs. The example I used with the president to talk about this initially was I drive a truck up to your construction site, Mr. President. It's got a lot of stuff in the back, and I say, do you want to buy the truckload of the stuff? And he said, well, what's in there? I don't know. I think I may have seen some bricks in there, maybe that, maybe not. And he says, well, were the bricks any good or the material any good? I have no idea, sir, what it is. He said, well, how much the damn thing costs? And I said, no idea about that, but you want to buy it or not? Do I get out? And you need to know what you're buying and how much it costs, both of those. So without the good transparency on quality and on the product itself and the records of the doctors and the healthcare providers, I was chairman of the board of Centennial Hospital down here in Nashville for 3 years here. And let me tell you, if you think you know the quality of the medical care, I'm going to tell you, you don't know nothing. We need to have transparency on quality, not only by procedures, but doctors, et cetera. And we also need to know what the price is. Together, that's where you create the competitive market. And that is very easily done in medical provisions. It really is easy to do. It's not like judging whether you like a poem or not. There are strict measures as to quality, and you can get groups coming in that will be able to interpret the raw data to make it so that consumers are very well informed when they make their decisions.
I guess I would push on this a little bit with my dear friend in that I think the quality issue is a lot more challenging to measure and much more difficult to communicate. We have currently over 2,100 quality measures in America. There are arcane measures, case mix adjusted excess rate of mortality, morbidity for condition A, B, and C. And most Americans understand 5-star ratings and numbers of reviews. And so being able to translate and communicate quality and being able to measure it are two very different things. And one of the challenges we also have here is more than just a load of bricks in the back. It's how you're going to use the bricks and whether you're going to put the bricks in right if you're measuring the outcome. And so much of healthcare is impacted by the patient's compliance, their behavior, their idiosyncratic adherence to the recommendations of providers. So this is not an easy question. We had, as part of the Healthcare Pricing Quality Transparency, HHS had the Quality Summit Committee that the Deputy Secretary challenged the industry to better rationalize the quality side of this. And there was 15 people on that committee. I was one of them, and it had the leaders in quality measurement in the country. And I think there was unanimity amongst the individuals in that group that we have not done a good job to date of measuring quality in ways that are reflective of the underlying true quality, or that are not manipulable, they're under provider control, all these necessary incentive properties. We have a lot of work to do in terms of the quality side of this.
It's amazing how things can be solved once incentives are put in the place. And there will be groups in there that will be able to evaluate this and make it specific. And given the value of this product, those groups will come forward and be able to give you a good notion of that. And these dynamic quality measures will occur and will proceed over time. Yes, you're right. The first day they won't all be there. That's true. But over time, you're going to get some very good indicators of quality go along with your price data.
Well, there's part of it is salience, and that's you do have things like provider report cards. You have things in nursing homes. I mean, there are steps in that direction. I think you're right. The incentives are haven't been there to. It's sort of just steps rather than you see hints of what can be done.
Let me tell you, Chairman of the Board, you also have some insight into the quality of the providers of health services in a hospital setting. There are those. These will become transparent. Other people will know those as well and be able to make good decisions. At least on the extremes, they'll be able to make much better decisions.
On the quality, I would encourage people. I think the best thinker in this area, at least who's influenced my thinking the most, is Marty McCary, who is a surgeon at Johns Hopkins University and who has put together a project called Improving Wisely. And really, they are looking at grading physicians, sort of self-policing, coming up with a set of appropriateness measures and looking at where physicians are on those appropriateness measures. The two quick examples. One, like what's an appropriate C-section rate? If you ask OBGYNs, they would say, well, C-section rates in excess of 50, 70% for uncomplicated, 50% for uncomplicated pregnancies, that's inappropriate. Same thing with back surgery. We know there's way too many back surgeries done. You can look at the percentage of times that a back surgeon will do surgery on a person that hasn't seen a physical therapist in the previous year. Sometimes surgeons are 100% of the time they do back surgery, their patient hasn't seen a physical therapist in the previous year. That seems
Brian,
like,
if I may say, that's exactly the example we talked about with the president going to this at the first time with the executive order. We talked about Tiger Woods and what happened with his back surgery, his spinal surgery, how he was delayed for 6 years. And the doctor then said, if you hadn't had it, you would have been able to go back right away. So, you're exactly right, but there will be procedures that can bring quality measures back into play.
Yeah, I mean, Marty is great, and I completely agree with Brian. You should all read, if you're not familiar with Marty's books, The Price We Pay, Unaccountable. They're must-reads. I assign them to all of my students. The challenge we have when we talk about quality in healthcare and value is there's some measure of quality in the numerator, some measure of cost in the denominator. And you can do really well in that equation if you treat somebody who should have never been treated. You're going to get great quality at low cost, and you would have completely destroyed value. So I have very real concerns about this value obsession and how we're going about measuring it and executing it.
And because of what Larry says, I am sure, given his knowledge, he will create a system that will solve that problem for people, and he will make it available for a price, and he will it'll be the best thing. That's what dynamic competition does. You can't do it today. True, at least not completely. But believe me, in 4 or 5 years, with these minds like Brian and Larry's minds on the issue, we'll have great quality measures and value measures.
And to Brian's point, there's a few. I mean, measuring risk or measuring quality in healthcare is hard in part just because you have to control for the underlying severity, the underlying, how difficult the patient is to treat. Even you can think of that with COVID-19. I mean, you have to measure whether any sort of treatment works, whether doctors are doing a good job, hospitals are doing a good job. You can't just look at a mortality rate. You have to be accounting in some way for the severity of the underlying condition. And that's hard to do, but it is also the subject of a lot of study and a lot of research, and we're getting better at it. There is also incentives, though, and to Brian's point about C-sections, one of the underlying issue there is, to me anyway, is what are the incentives, and if physicians are making more from a C-section compared to not doing it that way, and then the patients aren't paying more, their copay is the same. I mean, you have this misalignment of incentives. And I guess this is a question that's part mine, but it also is reflective of several of the thoughts shared in the Q&A screen, is kind of how it seems that transparency has to be coupled with cost sharing, that it has to be coupled with consumers, knowing exactly what the price is if consumers are, and you hinted at that already, if consumers are just paying a copay and it's $100 copay flat, period, end of story, what incentive would a consumer have to really shop around? And so I'd wonder, even if they did know the prices, and so I'd wonder, do you have to couple for price transparency to be fully effective, do you have to couple it with, say, a high deductible plan, higher cost sharing type arrangements, or would it work even in a,
Let me just say that price transparency, if I may on this, doesn't require an insurance company to exist.
Yeah.
Transparency is people being self-insured personally. They can go in and buy their own stuff that way. If it's what is the savings? What's the difference in the average price of a medical thing versus shirts versus cash? It's substantial. You save a heck of a lot not having an insurance company in the middle, except for those that have real risks of very small probabilities and very high costs. That's where insurance should be. Insurance shouldn't be insuring you for lunch.
And I'm old enough, and Art is definitely old enough, to remember the days when we had effectively catastrophic health insurance, employer-sponsored catastrophic insurance. It was called major medical. And we started in a world of major medical, and back in 1970, 40% of all U.S. healthcare spend was out of an individual's wallet. You paid to go to a doctor out of pocket. You paid for prescription drugs out of pocket. Everything was paid out of pocket. Why? It's efficient, it's appropriate, and none of what we're doing today meets the definition and theory of insurance. All of this is in the process of an unwind. To me, I showed you the picture showing that today we're at 30%. My forecast in the employer market is 10 years from now, it'll be 60 or 70%, which are basically high deductible plans, which are you're catastrophically insured, and you have an HSA sitting alongside it, and you're paying out of pocket, and it's going to look just like 1970.
And the whole point of insurance is you don't usually use it. I mean, you have car insurance.
You don't insure everyday things like lunch.
Yeah.
You insure catastrophic events.
Right. It's for
and that's where it should be.
Well, yeah, and up to half of people don't reach their deductible either.
That's right.
So I do think, though, this is all right. I agree with it all. We're talking at the consumer level. A large part of what I did in my piece for Galen is look at how price transparency will affect employers and how employers go about structuring benefit designs that they can create the right incentives. So I think if we're not thinking about the effect on employers too, and employer coverage, we're missing a big part of the picture.
And there's an assumption in here that it's going to be employers that are going to do the health care for the employee. I'm sure down here that once we get transparency, a lot of the employees would prefer not having company, but have a higher salary and let them handle it themselves. Now, some of them clearly won't, but there's no reason why that can't be the model as well. It doesn't have to come through employers.
You just mentioned one of my favorite actions of the Trump administration, where we allow employers to provide defined contribution amounts, so employees
Yay!
pick the coverage that works best for them.
Terrific, Brian.
You got all three cabinet secretaries, the HRA thing. That was awesome work.
Thank you.
It's true.
Great.
There you go. Does that answer your question?
It does. No, we're hitting good enough, right? We're hitting several, I'm kind of lumping several questions into my own words here.
Then we get the education system. Remember the next,
That's right.
it's going to be a year from now with education. We're going to be doing the same thing.
We can.
Art, I've got five kids. I've got 5 kids, and the oldest is 5 or 6 years away from college. So I'm glad you're turning next.
You got me beat. I've only got
The oldest kid in your case, Brian, is 10.
13.
Is they're saying damn bright?
Let me try to sneak in one more kind of broad topic that's a recurring theme here that I'm seeing. It is kind of this, again, I'm combining several questions into one here, but this is interesting. When we think about free markets, we tend to think about less regulation. And we're here today essentially talking about a new regulation for practical purposes. And it sort of points to this question of, well, why didn't the market, the quote, free market itself, why is price transparency legislation necessary? In other words, why don't private market actors kind of step in to fill this void? The question specifically I'm looking at, it seems there should be a market for an insurance type company who would do the shopping Dr. Van Horn illustrated for the employer. You know, what's the gap? What's the market failure? Why are firms not kind of entering into this price transparency void so that we need legislation?
So yeah, I'm very sensitive to that question because I think there's a lot of truth to it. The problem is that we have so many other regulations that have perturbed and destroyed a well-functioning market here, going all the way back to the tax deductibility of employer-sponsored health insurance, which completely reduces the compensation structure to slant towards health benefits. So with Obamacare, we redefined the definition of insurance to include the 10 essential health benefits. We've got all these regulations that have been put in place that we have been unable to strip out and unwind over the last 20 years. And that's a real problem, Brian?
No, I agree with that. I mean, we don't have a market for healthcare, government regulation, like Larry said, starting with the employer-sponsored exclusion. And, you know, the role that Medicare and Medicaid play in trying to set prices, and third-party payment. 90% of payments go through third-party payers. And I mean, I think ultimately we've been naive in thinking that insurance companies are motivated to lower healthcare spending. One of my sort of main revelations is that insurance companies are, if that's their motivation, they're really failing to lower healthcare spending. That they're making larger profits as healthcare spending increases, and they are fighting tooth and nail to keep these prices hidden. And I think that shows us that we need this price information, that it's good for consumers. It's going to lead to less revenue for insurance companies, to have employers and consumers knowledgeable about what's going on. So I oppose almost all government mandates, but here the market is so dysfunctional and largely because of government rules. This seems pretty benign level of regulation when we're saying, just show us your prices, show us what you're charging so we can have more information to be better shoppers.
You know, this has been an attack for economics for generations. There are such things as monopolies, duopolies, control of local markets, all of that stuff. You go to the Stigler, the Posner, any of those, that literature. What we're trying to do is create markets that act as if they were competitive. Sometimes natural competition isn't the order of the day, and sometimes a very simple order like the executive order for transparency will make it much more competitive in the process. And that's what I think we have today with this order.
Terrific. Well, we're at 3:30, so I think I'll go ahead and wrap us up. The questions were coming in faster than we could get them answered, so we ended with the same number we started with there. So I apologize if I wasn't able to get yours out. Hopefully we hit something that at least got in the direction of your question. We had 120 participants right to the very end of an hour-and-a-half event, so I think that means a lot of people were interested and engaged, and there was certainly a lot of discussion, and we hope we kind of gave everyone, the panelists gave everyone some food for thought and some new insights. So thanks to our panelists and to the 120 of you who made it on to the very end as well. And we appreciate it.